we've got a good number of people in the room now, so I think I'll formally start proceedings. So welcome everybody. This is a Grab the Mic webinar for the Beam Exchange. My name's Mike Albu, and I look after the Beam Exchange, a platform for sharing information and knowledge and experience and lessons about applying the market systems development approach. And today we're very privileged to have 3 speakers talking about the work that their program has been doing in Somalia and Somaliland on healthcare, which is quite an unusual sector for market systems development programming. So it's really interesting to hear this experience today. I'm sure you're going to enjoy it. So we're going to have Ron Ashkin, who's the technical director from DT Global Africa, and he's been doing this work for a while actually, because I've known him for a few years, and before, in the past, he was working on a similar kind of private sector healthcare market systems development program in Kenya called PSPH. And that was really the basis of a pilot which led to this program in Somalia. And then his colleagues are going to be, his colleagues Millicent Oketch, who's the program manager for PSPH, which is the Somali program, which is based in Nairobi, and Hassan, Eymoy, who is the team leader, also based in Nairobi for the Somalia work. So these 3 are going to be talking us through it. And before they start, I just want to point you to 2 things, 2 features of the Zoom space. I'm sure you're getting familiar with it now, but there's a chat box, and please use that chat box to introduce yourself or say anything you want to in general about the webinar while it's going on. At the moment, we've got 40 odd people in the room, so I'm sure they'd be interested to know who you are. But if you have any questions for the speakers now or during the course of the webinar, please put them in the Q&A box. Don't put your questions into the chat. Put your questions into the Q&A box, and then we can respond to them in the appropriate way. Yeah, that's it. Let's get going. So I think we're going to start by introducing. Right, we're going to start. You're Ron. You're going to kick us off, aren't you, with a quick overview of the PSPH program?
So thank you, Mike. Let me take a quick run through the agenda for today. So Hassan and Millicent are going to present. And basically, we're going to talk about the context of healthcare in Somalia. Like Mike said, it's quite unusual for a private sector program to be operating in the context. And then we want to talk about why market systems as a business case, as an approach in Somalia, which is a heavily donor-distorted market. But virtually everything else is a direct delivery program. And we'll talk about how our program operates, how we built implementation capacity where basically there was none. Hassan will give some really interesting background on the Somali business culture, why it's a unique operating environment for the private sector. We'll talk about some lessons we've learned in creating partnerships with the private sector in that context, and some challenges and solutions that we've found. And we'll capstone with some key takeaways. And after that, hopefully we'll leave about half an hour for questions from participants. I'm going to step out now and turn the floor over to my colleague Millicent, and I'll come back in when it comes to questions, and I'll participate at that point. So thanks everyone for joining, and we hope this is insightful for you.
So thank you very much, my colleague Ron, and welcome everybody. So the Private Sector Partnership in Health, which we also call PSPH, is a 12-year program in which SDC has mandated us to follow a market system approach. And the overall objective of the program is to ensure that Somalis get better access to quality and affordable healthcare services. And the program has 2 work streams. One of them is the healthcare financing, which is working on the demand side, and is basically to test low-cost health insurance products into the market. And the second is healthcare service delivery. And this is working on the supply side to organize the private sector clinical providers into commercial networks. And the program has 2 field offices that are shown on the map in red dots. One of them in Somaliland, Hargeisa, and the other office is in Somalia, Mogadishu. And currently the program has 10 running interventions cutting across the healthcare finance and healthcare service delivery. Next. So currently, this program of PSPH is the only private sector program using market system development approach that is existing in Somalia or Somaliland. And according to the UN financial tracking systems, there are about 81 health programs or donor-funded programs in Somalia. And looking through all those 81 programs, PSPH is the only program that is engaging the commercial private sector to implement interventions. And like I mentioned, again, being the only MSD program operating either Somalia or Somaliland, creating systematic change using the approach, of course, is new in this region. That means we've been building a lot of capacities to implement the program. And it's one of those programs that is a rare example of how MSD actually works in the healthcare, building from a pilot by SDC about 7 years ago in Somalia, and also FCDO in Kenya. Next. So this is just to give you a snapshot of how the healthcare environment in Somalia looks like. And from our experience, one of the things that we really noted very fast is that the context or the environment is very donor distorted. And I'll explain what that means. By donor distorted, I mean, for example, in 2021, we found that about $173 million was pumped into the Somalia health by donors. And that's actually just accounted for about 40% of the overall health expenditure. And at the same previous year, the budget from the Federal Ministry of Health for the same health expenditure was only $9.5 million. Therefore, you can see that huge gap that donors had to step in to fund. And that actually leads to that distortion, because the amount of budget needed to spend on the overall healthcare versus what the Federal Ministry of Health had, it's really uncomparable. And what does that means that also that the government is very underfunded, even though that is now been improving in the last couple of years, where we've seen donors like really the World Bank are coming in to build the capacity of the ministry to be able to deliver health services. And when I talked about the $173 million that went into Somali health expenditure, these funds really didn't go through the government directly, but rather are channeled through NGOs and UN agencies, which actually create a parallel quasi-public system, which is free to users. And that means that this money actually bypasses the government. Therefore, the government has little control on the design and implementation of the program. And like I mentioned, if this is only the 40% of health expenditure of Somalia, we found that 60% of health delivery in Somalia is actually taken up by the private sector. So the private sector provides 70% of overall healthcare services. But even with such a huge percentage of the market, we've also found that even though it's very thriving, it's very unregulated and fragmented. And another thing that we found out in the market is that there's no public health insurance available. And for those seeking care in the private sector, only 2% are currently able to afford health insurance, available health insurance products. So only 2% are covered. The 98%, it leaves a 98% who are paying out of pocket. And why are they paying out of pocket? Is because they cannot afford the available health insurance products that are in the market because they are too expensive for them. And another observation in the market is the Somali market is very data poor environment, and even where data exists, like in our programs, we have been able to come up with really good data, they are unsure how to use the data to make business decisions. Next. So this is just, again, a high level synopsis of what we have learned about mass market health expenditure. And the first thing that we've learned very quickly is that actually there's more money in the market or existing in Somali market than officially available or noted in the official statistics. And if you look at this pyramid, according to official statistics, there are about, according to actually international poverty line, 70% of Somali live below the poverty line, and only 30% are above that poverty line. These are official statistics. And the second one is that only 2% of the Somali population live above the middle income poverty line. And these 2% are the people I discussed in the previous slide that are able to afford the current health insurance product available and therefore have no issues paying for health expenditure or traveling out of the country to receive quality healthcare. And then of course there is the bottom part of the pyramid, and these are the people who cannot pay at all. We call them cannot pay. And these are the IDPs, people, a very aged population that depend on humanitarian aid and other NGOs for assistance to get health services. Then what we found out, interestingly, that is actually the inverse of the official statistics that are discussed that say that international poverty line that 70% of Somali live below. If you think about health expenditure, it means that according to official statistics, that 70% of those people living below the poverty line can hardly or cannot pay for health services. But what we found through our various field research in Somalia, both in Somalia and Somaliland, is that this is what we found is the inverse of what the official statistics say. We found out that there is a large market that is called can pay less, that extends way below the international poverty line. And this can pay less are people that are already paying for health services, except that they are paying less. Like we say that the government, the current donor funding only supports 40%, 60% in the private sector is taken up by private sector. So there are people can pay less who are paying less for health services, and they're already paying. And when we talk about, so what's the difference between our research and the official international poverty statistics? Is the official statistics, when they look at the ability to pay for health services, they look at the individual capacity to pay. While in Somalia, the social structure is very different. The social structure is that issues such as health are not handled at individual level, but are rather handled at nuclear and extended family levels. Meaning that if there's a health issue, it's not an individual issue, but the extended family, which are sometimes as big as 7 or even more, and extended, come in to pay for health. And therefore, when you look at that family, if you look at that family, extended family, if you look at also a large number of Somalis are in diaspora sending money home, and pooled family funds and community saving, people who can afford to pay less, whom now we call mass market. And we have found that they are about 70 to 80% of the population. And that is actually, they are the largest part of the health market, and that's why we call them the mass market. So from our research, we're saying that there are about 70 to 80% of Somali who can pay less. They're already paying. The difference is the current products are not tailored for them, and they're not getting value for money. And this is where PSPH is focusing on testing innovative products to cater for this huge 70 to 80% of the population. Next. So what is the case for MSD in Somalia healthcare context? I mean, just looking back at when you talk about the 70 to 80% able to pay, that it seems it's evident that there's a very large market that is currently being left out, and MSD comes in to test various innovations that can actually work with this for this market. And when that is put together, you can actually be able to build a sustainable market. And then another case for MSD is that what we found out, the local capacity is way underdeveloped, and most of it has been money-based behavior change. And these programs work on knowledge-based behavior change, and therefore been working on building local capacity that stays well past donor funding and direct intervention. And again, the case for MSD is MSD works to test innovative approaches, new innovation that are adapted to the context, and we experiment different low cost, if it's health insurance, or products that can work for the mass market. And actually in that context of testing, one of the intervention partners we work with is really at a high or advanced stage of developing a product that they might be launching in the market anytime soon that is targeting this mass market. And like I mentioned again, that the people who can pay less, we are called mass market, they are active and they're not really passive. Like we mentioned, they're already paying for help, they're not getting value for money, and therefore MSD being able to come up with innovative products that cater for their needs, it's a very good approach. And then the value for money, and value for money comes in MSD because once you give the private sector knowledge, they test, and this products or these innovations work in the market, they are able to continue on their own. Therefore, without needing more interventions, they're able to stay sustainable. And another thing is that as we worked in this market, we've realized that actually a big proportion of the private sector understand the pyramid. They understand that they're this market. They just don't know how to go into this market. And that's where we've come in, that we are helping them with the business idea on how to enter this market. Next. So how does the program operate? Like I mentioned, we are a business consulting firm and not a clinical consulting. What does that mean? It means that we are working to give help the private sector with information and knowledge to improve their businesses. And we do not give direct financing or cash to our partners, basically technical assistance. And this technical assistance is very needs-based. It's very customized to every partner based on their capacity and where they are. And some of the example of technical assistance that we provide on this project is maybe things like market research on the market willingness and ability to pay, and demand for specific health services. And we also help them with matchmaking, if it's organizing the commercial private sector into network, in developing their governance framework. We also do business skills training and etc. And PSPH, really the technical assistants follow very specific process, so we're not ad hoc, even though the technical assistants need-based, but there's a very clear defined process. And mail is actually, or data is collected by our field working on the projects on a continuous basis following the DCED standard. Next, Ron. So building implementation capacity. One thing we learned quickly in the Somali context, and I think most of you might agree that almost everywhere in the world, that for this kind of project in health, there's no really readily available consultant who are experienced MSD private sector health. And therefore we had to build this team from scratch. And that meant a lot of tailored and heavy training that have been focused on the team from day one. And that has really resulted now into a team which is very technically savvy in consulting and able to carry out, things like quick market research, such as surveys, and training our partners even in conducting strategic action plans, which otherwise would have been contracted to a third party to undertake. So our team is now really at an advanced stage that some of this we are saving and they are able to work with the partner from inception to product launch. As I mentioned, that one of our partners is in the advanced stage of launching a product. Another thing that we've done to build our capacity of our team is frequent lessons learning. And we've done a lot of lesson learning from, of course, the successful interventions and the ones that have failed, because sometimes, and not sometimes, actually failure create lessons for new interventions that are being built. So we learn a lot of lessons from both success and failure that when we start new interventions, we build on. And of course, even for our intervention partners, we mentioned that creating systemic change using MSD is very new. And that means it's been very new for our partners as well. So, and also just that behavior change from money-based dependency to knowledge requires a lot of patience and capacity building. So we've been building capacity over both our team and our partners that we work with. So thank you very much. And from there, I'll hand it over to my colleague, Hassan. Hassan, over to you.
Thank you so much, Millicent. And good afternoon or good morning, everyone, wherever you are. I'll pick from where my colleague left. To introduce the project into the market, we have to understand the business, the Somali business culture. And Somalia has a very vibrant business culture where most of the businesses are family owned, and it is heavily reliant on trust with very limited written contracts. These family-owned businesses are largely small-scale businesses, but limited corporate entities are emerging after years of operation in small scale and absence of governance structure in place. Corporate entities are emerging and taking shape in the country. Contrary to popular opinion that Somali women are not active in the social setup, actually Somali businesses are largely owned by women. And we have seen women operating in all stages, both small scale and large scale entities, and rising all the way to the CEO level in companies and also owning businesses. So Islamic values are highly cherished and highly considered. Entities like insurance operating in a form that locally is called takaful insurance, which is an Islamic insurance model, which is more based on cooperative insurance than the conventional one that is widely known. Next, please. In working in Somalia setting, we have to understand the operating environment. Our operating environment is quite unique. And some of the lessons that we learned in creating the partnership that we have is that largely Somalia is built by the private sector. After the fall of government nearly 30 years ago, the sector is booming, largely referred to as economy without government. So the country is largely built by the private sector. So the private sector is quite critical in all sectors of the country. And because of the limited opportunities in the country, we have seen there is extreme competition for resources. We have seen instances where there are monopolies exist in importation business, and businesses are largely ad hoc, meaning people have resources and waiting for opportunities to invest, and as soon as the investment is done, they pull the resources into the other business opportunities. But in the business, in the health business, we've seen steady growth both in pharmaceutical sector and also in clinical sector, in hospitals. We have seen steady growth and strength after strength, and companies emerging as very strong players in the market. Trust is critical, as I said earlier, because written contracts are not widely popular. And once the trust is established, you are able to work with the partner long term. As my colleague mentioned, the market is data poor, but we have also realized data can be generated much easier much quickly using different mediums that we have been using, like market surveys and FGDs. And use of this data is limited, and that is where we also come in to support our partner. The tendency to corruption is quite common, both in the private and public sector, sometimes hindering engagement, where individuals ask what is in it for me, for them to come in. Next slide, please. In managing partnership, what we also learned is that working with local permanent players is very critical, because these local permanent players are the ones who retain this knowledge in the country and are likely to work long term in the country. And in engaging with our partners, identifying the right partners to work with, we do extensive due diligence where we are able to talk to the key decision makers in the company, screen them for compliance with the concept of MSD that we are looking at, which is a more mass market oriented, and we set the appropriate expectation so that the partner will not come back to us for resources or for money at a later stage. Definitely, yes, there are instances where partners have come back to us for resources, but we again revisit the approach that we are using and set the appropriate expectation so that the partner fully realize that our behavior change, creation of behavior change in the market is knowledge-based and not cash-based. Further, in managing partnership, next slide, please, we also come to realize that it is very, very critical to engage the partner and work with them as partners, like as co-workers, more or less like co-workers. Our field staff are more or less like co-workers with the team working for the various partners that we work with, to build trust, to work with them on a daily basis, experience the market reality on the ground, and then build that confidence and work with them, looking fast, generating fast on the challenges that they encounter, and see how we jointly adapt our technical system to support them. Further, we realize that entrepreneurial workers partners are much more reliable and understanding the business value of knowledge creation, unlike the cash exchange in hand. And but while the institutional workers that we work with, which are more professional entities, seek handout more than focusing on creating the opportunity in the market that could expand the opportunity for them. We keep active pipeline of interventions, seeking new interventions every time. As my colleague explained, we have 10 interventions currently, but we keep prospecting for more. So anticipating that some of the partners might not be able to go through the entire journey with us to create product that is suitable for the market, or the business model might change anytime because of the corporate decision that can be made. So we keep prospecting for more, and at any given time we have different partners focusing on different areas that we are working, the two streams that we are working in. Next slide, please. And the remaining, in the next two slides, I will cite some challenges that we encountered in the market, which we already have alluded to in the previous slides. One of the major challenges that we encountered is immature corporate culture, because the setup is largely family-owned small-scale businesses, but the emerging corporate entities like insurance companies and hospitals that we work with have very weak corporate system in place, where they are disconnect between the board members who owns the organization or the CEO who owns the organization and the operational team on the ground, on understanding how they will work with us, how information will be shared, how the decisions, the data that we generate could be turned into useful decision for the company to implement. We are able to overcome some of these challenges working with our partners by making an extensive introduction of our approach to a broad-based team comprising of middle-level managers and senior managers. We are also able to unpack their strategic plans to see how best we can help them develop it further to respond to the mass market need and see the opportunity that is in the mass market. On the other hand, we realize there are weak regulations on the ground, and as I said earlier, accountability is an issue. All this we are able to navigate through as we build partnership in the market. The next slide. On this slide, I'll also mention this one of these challenges in the interest of time. As I said earlier, working with entrepreneurial partners has been more fruitful than working with institutions, because institutions that we work with, professional entities that we work with, have very limited structure, management structure in place, governance structure in place. And because of this, they tend to take their time to understand how to work with us, how to develop their own capacity rather than responding to the market need. We have seen that there are also limited opportunity, limited existence of commercial networks, apart from the affiliate that my colleague mentioned earlier, which was piloted, developed through a pilot supported by SBC and implemented by DT Global. This weak institutional framework that institutions that exist requires a lot of investment to build their capacity, to help them understand how best to operate in the market and bring the market players together. With time, they are able to understand this, but it takes a much longer time working with them compared to entrepreneurial partners. Yes, some partners would come back and ask for hard cash, but we kept explaining the approach. And so for those partners who persist, then our relationship is terminated. Poor infrastructure are some of the other challenges that we encountered. Now to sum this, to put all our discussions in summary, I will now take you through some 8 key takeaway points that you should remember. Even the other slides here are not taken enough notes. Next slide, please. Some of this key takeaway that we put for you on this slide is one: the market has been heavily donor distorted for many years, and the behavior change have always been realized through money-based relationship. Ours is more knowledge-based relationship, and knowledge-based relationship is able to remain in the market and add more value to the market, unlike the cash, whose goal cannot be easily, or impact cannot be easily felt after the termination of the relationship. On the other hand, as my colleague explained, there's opportunity for MSD to succeed in the market because of the large mass market population that exists, or the group that we refer to as mass market, whom we realize are nearly 80% of the Somali population and very active in the market in terms of expenditure on health and other services. On the other hand, and for you to entrench yourself into the Somali business system, and also to effect more long-term changes in the system, we have to adapt to the unique Somali culture, where trust is very critical, confidentiality is highly, building a relationship is highly considered, and also adaptation to the dynamics of operating in an insecure setup like Somalia. On the other hand, continuous follow-up of partners are very critical. At any given time, we ensure our partners are fully on track. When we are ending a meeting, we have clear understanding of where we are heading next, because the partners don't know our timeline, the project timeline, and they might take their time. Therefore, keeping them on continuous follow-up to respect the timeline and also their internal timeline is very, very critical. Permanent local capacity needs to be built, which is the essence of sustainability. And this we build through engagement with our partners, training their teams, and also exchanging with our team on an ongoing basis, where relationship is not just limited to the formal meetings that we have, but going beyond and working with them at any given opportunity. On the other hand, adapting to the environment is very critical. So we run a very dynamic portfolio where we work with our partners and adapt it to the context that they're operating in, which are largely the context that they're operating in. And then we also learn from instances where partners might not be able to go through the full length and introduce the kind of product that we require them, that is required in the market, to respond to the mass market, because we take failures as a success technique. The data that's not existing in the country can easily be generated, and also the partners assisted in terms of data analytics and applying the lesson, the findings into their business. And finally, we have what we call next step obsession, where we don't leave our partner without knowing what we are doing next, and without them also having clear understanding of that whatever we are doing next is adding value to their business. So thank you so much for listening to us. We summarize this into these 8 takeaway points, and I'll hand over to my colleague Ron to moderate the remaining part of the session. Thank you so much.
Thank you very much, Hassan and Millicent. That was a superb presentation. Ron, do you want to moderate these questions answers, or shall I carry on in that role?
Well, we've got quite a few into the Q&A box.
Yeah, we have.
And, yeah, Michael, why don't you throw them at us, and I think the three of us will.
Just before we look at the questions in the Q&A box, I have a question actually. Could you just whip us back to, I think it's slide 9, the one that's titled how the program operates. So I just wondered actually whether one of you could just go a little bit more detail into these bullet points around the exact nature of the interventions that you're providing. And in particular, what I'd be interested to hear about is any specific intervention or innovation that you feel is really making a difference.
Yeah, I mean, the program's just in its 2nd year, and actually SDC's scoped 12 years altogether. And what we're working with, there are 2 work streams. One is in demand side finance. So it's healthcare financing for the users, not for the suppliers. And like Millicent pointed out, 98% of the private healthcare is paid out of pocket. So we've actually found a lot more interest in the market among the commercial insurers. Once they see the pyramid slide and they see just how big the mass market opportunity is, they get very interested in investing. Because right now what's happening is the health insurance serves 2% of the market. Ironically, most of that 2% are the donor project employees and the NGO employees and the UN employees, because the product's really expensive. It costs almost as much in Somalia as it does in the West. So for the average person whose family income is $250 to $500 a month, they can't afford it. So once we show the private insurers that already have experience in the market, but at the very top, this is what the opportunity is, we've had a lot more interest than we expected. In fact, we have one product, hopefully it'll get on the market very soon, but they look at willingness and ability to pay through the market research that we did for them. And then they look at what benefit package is actually serving the needs of the population. So we look at what services are used. So yeah, I mean, in healthcare finance, we found a lot more interest than we thought. When we came out of inception, we thought it would be really difficult to get traction in the health insurance field. And again, one reason the program scoped for a long time is with insurance, you can't just launch a product and say it's successful. First you have to sell the product, then people have to use the policies, then they have to renew their policies. So it's kind of a long-term investment on the part of the company. But really, all that money is being invested by the companies themselves. So that's one area that we found really fruitful. On the other hand, on the service delivery side, we found that there are a lot of underutilized assets in the private sector, specifically in specialty care. And also we know the government's working on an essential package of health services right now. They're mostly delivered, through this quasi-public, NGO UN system. But they're interested in bringing the private sector in. And basically all of the hospitals that belong to Ofinet, for example, are able to deliver almost all the basic services. They just don't know what the government's looking for. And again, it's an underregulated market. The government's way underfunded, and the private sector is quite fragmented. So we try to find the ones that actually agree with our objectives, which is bringing more access to affordable quality healthcare to more Somalis. And again, when the hospitals see the pyramid, they're interested in expanding their services. So yeah, I think health insurance and service delivery, both basic services or primary services and some more specialized or advanced care. We found traction on both sides. But I hate to declare victory, in the second year of a 12-year program. That's just the nature of the market. It's very dynamic. And Hassan, Millicent, you may want to add to that.
Yeah, let me come in. Yes, the market is quite dynamic. We are in the second year now, working with partners. What we have seen is partners require a different kind of support. So the support that we give to partners is not really fixed. It's based on the partner need and the speed at which the partner moves and the kind of objective that they want to reach in introducing product into the market. Like my colleague mentioned, one of the partners at the advanced stage of launching a public health insurance product, which will be available to individuals and families. And it was a journey working with the partner through every step of developing that product from scratch, from researching the market, understanding how the market operates, what the market needs, what the client asking for, what exists now in the market, and finally come up with a product that responds to their need. So it is quite adaptive to specific partners. So the technical support that we provide is quite dynamic and it's quite different from one partner to another. There could be some similarities at the onset as we say, set the stage of establishing the relationship, but in the end, it takes different pathways. Thank you.
Thank you very much, guys. That's great. So let me start with a quick question from Katie McKee from WHO in Somalia. And she asks, were the partners that you mentioned existing service providers, or have you supported new people, new businesses to launch? And secondly, has any of this been trialed in rural areas? And what were the differences between the urban and the rural markets?
Yeah, Katie, thanks for your question. We mostly work with existing players in the market. We've got one intervention where it's actually a startup, but it was driven by an entrepreneur that basically is in sync with our project objectives. Startups are fairly difficult to work with just because of the financing aspect and the instability. What we found was existing market players, a lot of them have excess capacity. Even though they're thriving and booming, a lot of them are only serving 50% of what they could serve. So our first objective is to network them together and reach more people. So I'd say primarily existing providers. They also understand the business environment. A lot of them have been in the market for quite a while. So the peculiarities of the family structure, the spending patterns are all familiar to them. In terms of reach, the AFINet is starting to expand outside of Mogadishu. We started in the main population areas. So yeah, basically Hargeisa and Mogadishu is where we started. Again, the private sector is investing and they have to at least break even or make a profit. We found that a lot of the larger hospitals in AFINet, for example, do outreach. So they do medical camps in rural areas. We've also found on the insurance side, because of digital products, it doesn't matter where you are. So if you can pay the premium, you can get coverage. So yeah, we're looking at expanding the networks outside of Hargeisa and Mogadishu, and we're looking at, on the financing side, using digital where we can. And again, the providers actually are quite behind nation building, and they do run medical camps, which serve a dual purpose. One is to reach outside where their facilities are located, and two is to bring people in for higher levels of treatment that don't have providers in their locations. Yeah, and it's kind of too early to measure differences in areas of operation.
Thank you, Ron. So look, keeping on the big question topics, Chris Masilla asks about engagement with the public health sector. And also Abdu Rashid asked a very interesting question about whether there's any way, whether it's possible to develop a package that's privately delivered package that's consistent with the Somalia essential package of health services, which he calls the EPHS, which is the minimum public health services offered at the public health level. So I think those two questions kind of go together. Would you like to have a bash at that?
Yeah, hi Chris, good to see you. Yeah, basically the entry point is through the networks, and we're actually at early stages of developing that relationship. The World Bank is running a program that's quite large in building the Ministry of Health capacity in Mogadishu to contract services. And right now, they're letting the very first direct government contracts for service, but it's all to the existing NGOs. So the next step is then to go to the private sector. So we've already been in discussions with them about that. And one of the reasons to strengthen and enlarge the private sector network is that the essential package of health services can be provided through the private sector, but they have to know what's in there, what the standards are, and what the reimbursement rates are, right? So then it's a business decision, but for the government, it's much better to engage with a network that has members, by the dozen rather than one by one, to find providers in areas. So yeah, the AFINET has a person that's on the current public-private dialogue working group with the Ministry of Health. So we've engaged, but it's at a very early stage. And in terms of National Health Insurance Scheme, I know early on in the project when we first engaged, the problem is where does the revenue come from to pay for that scheme? Because the tax base is really minimal. And I think that's the question in terms of sustainability. In the long run, we want the resources to come from inside Somalia. And actually right now in the private sector, like Millicent said, there's a huge portion of the population that's economically active, and they can pay, but they can pay less. And we're not saying they should pay, we're saying they are paying right now, but they're not getting good value for money. Their finances are not organized. They go repeatedly because they don't know where the good providers are. So we're just trying to mobilize the money that's in the market now. And that applies to the public sector as well. If there's a tax base, absolutely there should be some national safety net. Right now there's no tax base, so they're totally dependent on donors.
Thank you, that's really interesting. And maybe that actually answers the question that Rachel Macharia just posted. I don't know if you can see that, Ron, about the chance of sustainability for healthcare financing. I mean, essentially, what you're saying is that the exit strategy is built into the whole model from the beginning.
Yeah, I mean, we don't do exit plans. We basically work interventions with the partners. And again, it's their money being put in. The amount of money put into TA is minuscule compared to what an insurance company is going to invest in launching a product. So the chance of sustainability, that's up to the market. I mean, none of us has a crystal ball. What we found is that there's a lot of interest among the commercial insurers because they realize that 2% is saturated. Right, and they also realize it's unstable. Projects come and go. So one year you have good revenue because a project contracted you. In fact, DT Global, the company I work for, has a project, where one of our insurance partners insures their employees. But they realize that project may go away in 2 or 3 years, and oops, they just lost a big piece of business. It's unstable and it's very small. Plus, all the insurance companies are piled into that 2%. So where do they want to go? They want to go down into the pyramid, right? So from 2%, 5%, 10%, and whatever the uptake will be. So it becomes a question of, is there value for money in the product, right? Do people see value and they actually save out of pocket, and they have fewer medical emergencies in the family where they have to call on extended family and diaspora for payment? And then do they renew their policy? So yeah, we don't have a crystal ball, but it makes a lot of business sense. And the ultimate judgment's up to the investor.
Sure. Did you also, Ron, there's a question from Abdul Razak Osman about talking about a national health insurance scheme for Somalia. I'm not quite clear if that's a scheme that actually exists or it's just something that's kind of a policy idea, but the implication is, the question is that you could begin by targeting, say, government employees, which is 14,000 people and sort of scale up from there. Have you seen, does that make sense?
Well, yeah, again, the various insurance partners have different targets. And a lot of their information is confidential. We can't talk about specific companies and their target audiences, but yeah, the different insurance partners, they have to target a pool in order to do the actuarial calculations. How many people are there? How often do they use services? What services do they use? How much do they cost? What premiums can they pay? So there are different targets. And yeah, I mean, an aggregation like this is a likely target for a commercial insurer.
Right. Okay, let's move to a slightly different topic here. There's an interesting question from Thierry. I'm not going to try and pronounce your surname, Thierry, sorry. What in the sector are you taking into account issues to do with sexual rights and maternal health, and how is the private sector committed to ensuring that services are available to vulnerable populations like those?
I've been talking a lot. Why don't I let my colleagues start answering some questions? And Millicent and Hassan, if you want to start on this one.
Okay, thank you so much, Ron. Let me come in. Thank you, Thierry, for that very interesting question. The partners that we work with largely focus on primary and secondary healthcare. And these are the mass population that we are targeting. The primary healthcare encompasses the basics or the reproductive healthcare and also services which could be tailored for youth. But we are yet to reach that level with partners. But the packages that could be developed at different stages can take that into consideration, because as packages are developed for the mass market to take up, the market will dictate the kind of services that can be altered or can be improved, and therefore a different component of services could be offered at different stages by different partners to ensure that the vulnerable populations get access to health. This is actually the essence of MSD, where as much as possible, the mass population are able to afford quality healthcare from the private sector. And also when they need, they can also go to the free service which are offered by the government sector. So the essence of MSD is open up the market so that as many Somalis as possible of different social status can access services in the country. Our goal, if you can remember the pyramid, is to expand the mass market downwards to reduce the humanitarian dependence population as much as possible. Yes, if you can look at that slide, go to the mass market, the big blue. Yes, our goal in the MSD is to expand this big blue triangle downwards to reduce the cannot pay or the humanitarian dependent population in the country by coming up with packages where now the local business players can come up with packages that are affordable to the population, either through insurances, which are locally owned businesses, or through other mechanisms of pooling money that we explained earlier. Thank you.
Right, thank you very much, Hassan. So there's an interesting question from an anonymous attendee. Maybe it's someone from SDC. Do you think, Ron or Millicent, do you think that the TA and the other forms of facilitation that you're providing are enough to incentivize a systemic change here? I mean, to really change the whole dynamic of the Somali healthcare sector?
I think from one of the points Millicent made about the case for market systems is there's a lot of distrust between the public and private sectors. So a lot of times the private sector is looked at as they're all sharks and vultures. And sure enough, there are plenty of sharks and vultures in the private sector. They're opportunistic, they overcharge, they don't give good value for money. But we found a huge proportion of the private sector actually is interested in reaching the market with better value, better accessibility, better quality, and they agree with our objectives. And that's one of the reasons we're trying to build networks of these providers. So the consumers then see who the good guys are, if you will. and avoid the sharks and vultures. So we'll never control the whole market that way. There are a lot of people when they say, you don't have money to give us, nice having tea with you, see you later. But there are plenty once they understand how we can help them improve their business and grow their market, they hop on the bus. So yeah, I think there's a significant proportion of the private sector that's underutilized in terms of the overall health system. And again, we're at the very beginning. We're a small program among almost $200 million in direct delivery programs, right? So hopefully it'll expand from here. More funding agencies will invest in the private sector, and in a way that's sustainable where they don't expect more money next year. So yeah, we have high hopes for that.
Do you think, with a donor audience in mind, that there's any scope for shifting the norms around how healthcare should be provided in a country like Somalia?
It's a pluralistic system, right? But Somalia is very interesting because it's not public sector, private sector. It's public sector, quasi-public sector, private sector. And the true public sector, the Ministry of Health, and the government delivered services and regulatory environment and enforcement is really small. So we've got this kind of proxy public system, and then we have a big private sector, but it's unregulated. So I think there's huge scope to bring the private sector into the overall system. First of all, to talk about regulation, because again, with the networks, we're trying to do private sector regulation of quality standards, which may not exist in the public sector. And again, use the local resources that are there already, to organize the system. So that's kind of a long-term goal, but I think there's a lot of scope for investment in bringing the private sector's power into play. The private sector essentially has unlimited ability to access capital. There's a huge Somali diaspora. We're working with several entrepreneurs that have returned from the US or UK or Europe and have set up businesses. Why their family's there, they want to help build the country. So there's some serious players in the private sector. Plus, we've seen a lot of investment from, so-called South-South. And Turkey's not exactly in the South, but there's been a lot of Turkish investment in the sector. A lot of products come from India, for example. So there's quite a bit of flow in the private sector that's just not recognized in the formal system.
Thanks, Ron. So look, we have kind of run out of time. So before you all disappear, I'd really like to encourage you to click on the link that's just been posted by Isabel to fill out a sort of short survey form about this webinar and what you thought about it. We're really keen to know about your experience and whether you've got any advice or feedback about how we run this webinar. As I said at the beginning, if you are part of an organization that has a program you'd like to talk about, this is the space to do it. So I would also encourage you to let us know if you want to grab the mic yourself. But otherwise, how should we wrap this up, Ron? I mean, we could carry on. There's still a couple of questions here if people want to hang on. I realize that some people will have to leave. But maybe we could just, there was a question right at the beginning, Millicent, about the study that you mentioned, and it was particularly from Marina Madio, and she said, she wanted to understand about the impact of the COVID-19 pandemic in Somalia and whether that was part of the sort of dynamic of what was going on in the system there at the moment.
The baseline year for our inception was 2020. So it was right during the COVID year. And actually, we haven't updated the inception data, but what we found is from talking to our partners and players in the market, light bulbs go off when they see that slide. And the private sector players, actually, when we first did the pyramid, we estimated maybe 50%. But in engaging with the private sector players, everyone says, no, you're underestimating. It's 70 to 80%. And again, without a population, census, it's difficult to say. But we've done, statistically representative samples of quite large populations, and we found, basically how people spend, where they spend, how much their family income is, how much their health spending is. And it indicates that even now, post-COVID, that number is bigger than we initially thought in inception. Marina, I believe through SDC you can access the public versions of the report. So, but again, the inception report was done baseline 2020. It was released in 2021.
That's great. And I assume it may be available on the Beam Exchange, on the profile we have for your program as well. Okay, I'm afraid we've run out of time. So I just want to say a huge thank you, Millicent and Hassan and Ron.